Thank you. Thank you for the invite. So most organizations have figured out the way to pack a room is to use the words marijuana or cannabis. So this talk has nothing to do with that. I'm here to sell you some cars. So thank you for coming, and we'll talk about the Kia Sorento. No. So let's talk a little bit about the role of cannabinoids. So the title was marijuana, and we're trying to move away from the use of marijuana, which was actually coined by the American government many years ago when during their sort of initiation of this prohibition period, this extensive period of prohibition that we've had. And so really the active ingredients in cannabis are cannabinoids. So we're going to talk a little bit about cannabinoids, and I'm going to try and explain to you the role of this plant in medicine, as a medicinal tool. And I'll touch a little bit upon the recreational aspects of things as well as we go along, because I think that comes to mind with the new rules that are coming up and changing in the near future. So let's see if I can, it works. So we'll start out by asking the question, what is pain? Because that's what we're talking about. We're talking about the role of cannabinoids in pain management. So pain is a physical suffering or discomfort caused by illness or injury. It can be physical in nature, it can be mental, and often it's a combination of the two. And usually it initiates with some offending aspect, either a broken bone, a pinched nerve, something like that. That message is then transmitted up to the brain, through the peripheral nervous system first, through the spinal cord afterwards, up to the brain. It's processed in the brain. That's kind of the mental aspect of things. So it's processed up in the brain, and then there are subsequent messages that go back down to the painful area to try and limit the amount of pain and to activate inflammatory responses and healing processes and other things that take place. So that's kind of the basics of how pain works. And really, we can kind of divide pain up a little bit more so that we all kind of start at the same foundation of what we're talking about. So pain can be divided up into an acute pain process, which comes on really quickly, lasts for usually a relatively short period of time. It can be chronic. It can be lasting forever. It can come on slowly. Often it's indolent, might be sort of a 2 or 3 out of 10, or it could be higher, but it's chronic. It lasts for long periods of time. And then we have components of breakthrough pain, and breakthrough pain basically are where you might have a chronic level with exacerbation, so periods of really acute drops in between the chronic, and that's sort of breakthrough pain. The pain can be as a cause of either a muscle or a bone or something more hardware origined from joints and muscles, or it can be more visceral, the GI tract, for example. And visceral pain tends to be more squeezing and uncomfortable in that fashion. And then it can be neuropathic as well. And that's kind of what we're going to talk a little bit more about today, which is the neuropathic pain. The neuropathic pain really is a result of usually some form of damage or pressure to nerves. Often we'll have some sharp or shooting type pain, burning type discomfort. It's often associated with inflammation. And that's important to keep in mind. Inflammation often makes the pain worse in this scenario. All right? It often tends to be chronic, and then it has subsequent sequelae of the pain being present, such as fatigue or weakness. And it tends to be one that's more, it's harder to treat. You know, the Advils and the Tylenols of the world don't tend to cut it for this kind of pain often. What is the effect of pain? So I don't think I have to tell anyone this, because I think you all have at one point or another had some level of pain or discomfort, and you understand that it can be quite frustrating. It can cause anxiety and anger, fear, depression. It can lead to poor concentration and memory. It can have sleep deprivation and fatigue. So pain is not just the symptom of pain, but it has a huge rundown effect, a sequelae again from that. So what are the painful episodes in myeloma? It's often, so first of all, pain is the most common symptom in myeloma, affecting up to 80% of patients at some point or another. the sensation which causes discomfort or distress, and is often a signal that the body is dealing with an injury or illness. The brain gathers this information, as I showed you pictorially earlier on. It gathers this information, it processes it, and then it sends out signals. And usually, traditionally, we think pain was caused because of a means of the body trying to protect itself, right? So it's a warning system to the body to not, exert any more, pressure or downside to that area that's hurting. So it's meant to be a protecting mechanism in there. The common symptoms and complications of myeloma pain have a significant impact, of course, on the quality of life, as we have discussed briefly. And so controlling this pain can have a lot of impact on a lot of other aspects of your life, including the sleep, the anger, the depression, et cetera, that goes with it. All right. So the pain that we get most often in myeloma is often associated with bone-related pain. It can be due to thinning out of the bone or osteopenia, and it can be resulting from lytic lesions that may cause dull, achy pain on an ongoing basis. This is, of course, prominent in myeloma, and also present in many other cancers. I deal a lot with prostate cancer in my business, and I see a lot of prostate cancer, metastatic disease to the bone, and bony-related pain as a result of that. So, and it can be quite and very debilitating for our patients. You can end up with bony fractures, and these can be compression fractures in the spinal cord, for example, or they can be outright fractures of long bones, femurs, and the arms, and things like that. So when you get bony destruction, you end up getting various different sequelae of that itself. So you can get high levels of calcium spilling into the blood, and the calcium itself can go through and start to cause grief in the gastrointestinal tract. So you can get abdominal pain, vomiting, nausea, etc., as a result of the hypercalcemia that takes place. You can get peripheral neuropathies because of some of the drugs that we use to treat the cancers. And then there are, of course, paraneoplastic syndromes, or there's proteins that are released from myeloma and in other conditions as well, other cancers as well, that can get deposited on nerves and irritate the nerves themselves. And that's a kind of a neuropathic pain that evolves from that. So traditionally, when we treat pain in, let's say, myeloma, you might be treating the primary cause, which is the cancer itself. And then you might be also using painkillers. And there are various different pain medications that we, as physicians, have in our armamentarium to utilize for patients. And these include things such as anti-inflammatories. They can involve things like Tylenol. They can be things such as antidepressants, such as amitriptyline. And there can be what we call neuromodulating agents, such as gabapentin and carbamazepine. And sometimes we use steroids to try and help with the pain as well. And of course, opioids are often used as well. Tylenol 3 with codeine, or fentanyl, which sort of has a nasty kind of tone to it in the recent, because of what's been happening out there. So these are great if they work, but they don't often work. And the problem also is that we can get substantial side effects from treating with traditional pain medications. So narcotics, for example, can result in constipation. And I've seen patients who have had such severe constipation and abdominal pain that it can be very debilitating. They're housebound, and they have a real difficult time managing it simply because of the constipation. Of course, there is the narcotics have effect on your central nervous system, and they can make you dopey and be difficult to drive and tired and sleepy. So there are a lot of side effects from the medications we use. And narcotics aren't the only ones, right? So the neuromodulators can do similar things, and even the tricyclic antidepressants can do the same sort of thing. So they all have side effects that we have to monitor for as well. And if you can find a balance between the positive effect of the medication versus the downside, the negative effect or the side effect, then of course you have a winner, right? You have a pain medication that's working for you without a lot of side effects. But often, as I said, that is not the case, and you have to escalate it to try different drugs and different treatments. And we also try various non-drug treatments, which are fantastic: exercise, diet, heat, etc. Having gone through that, you do need to escalate things sometimes. And the Canadian Pain Society has a treatment algorithm, which in the last iteration has included cannabinoids. So this is kind of a real breakthrough, a real move forward, I think, in terms of our society and how we think about the use of cannabis in the treatment algorithms for pain. So as you can see in this publication recently, you start out with all the traditional ones, and absolutely as a physician, that's exactly what I want to do. I want to try my patients on the traditional treatment first, see if it works, along with all the ancillary treatments that we talked about with diet, exercise, etc. You then escalate it. If that doesn't work, you might go to something that's a little more, have more side effects, possibly more risk, but may have a benefit as well, such as tramadol and opioids. And when that fails, this is when we start to think about cannabinoids. And I'm going to discuss with you in a minute here what the evidence to support that is. And then, of course, there are a bunch of other fourth-line medications that can also occur, that can also be used. Sorry, I'm just going to keep an eye on my time here. That can also be used for treatment when cannabinoids and other traditional medications don't work as well. And these are listed over here as well. So plant therapy for pain management has a long-standing history. You know them because you've used them, all right? So for example, the willow bark gives us aspirin. I would hazard to say that just about 99% of you have taken aspirin at some point in your life. And that resulted in us learning about how that works in our body. So when willow bark derived aspirin, and aspirin, we went and asked how does it work in the human body, we discovered a system called the prostaglandins. Same thing with opium. So the poppy seed, the opium poppy seed, gave us morphine. Morphine is a drug, again, that, in the narcotic family, and then we've got a bunch of synthetics that have come along since then. But that's a pain medication that you are all familiar with, or at least are aware of. And that, in fact, resulted in us learning about the endorphins in our own body and the enkephalin system as well. So we learned about that as well. Well, cannabis is no different. So cannabis itself, which comes from the cannabis plant, we have now started to identify the active ingredients. I shouldn't say now, it's known for many years, but we're starting to learn more about them now, what the active ingredients are in this plant, just like aspirin, just like morphine. All right, so THC and CBD are two active components that are inside the cannabis plant that we utilize for pain management. We utilize it for a lot of other things too, but we're going to talk about pain. This has resulted in us actually learning about how that works, and that's through the endocannabinoid system. So the endocannabinoid system is extremely well studied, really well known, and teased apart down to the molecular and cellular level. We have a really good understanding of this system and how it works. We're now discovering how we can manipulate this system so that we can get better pain management and other benefits that cannabis has. All right? So, as I said, plants have a long-standing history in pain management, goes back over 3,000 years. Egyptians have, there's evidence where Egyptian relics dating back to the 16th century BC appear to have ascribed medicinal benefits to cannabis. So when you look at it internationally, there is some strong evidence of long-standing use of this plant. And I won't go into why we have really kind of created this taboo around cannabis, but there is a specific lineage of how this came about through the American government. We can discuss that one-to-one at some point. It's an interesting story. So does cannabis have any evidence for success and use? And the answer is yes, it does. All right. So I'm going to give you the pro and the con. So there's multiple randomized controlled trials, which are in medicine we consider, sort of the pièce de résistance of studies that are done, and there are multiple trials done in various different disease entities, such as HIV or multiple sclerosis or chronic neuropathic pain. And these randomized clinical trials have, on the whole, shown a benefit for the use of cannabis. And these are just some of them listed up here. There are many of my colleagues that would say, well, there's no evidence to support the use of cannabis. And they will quote a number of articles showing that there's no benefits. So I'm going to try and explain to you why there exists some controversy in medicine and how we're getting about that controversy now. But there is evidence, and there is evidence to support the use of this plant. What's interesting, though, is when it comes to plant therapy, unlike traditional pharmacological therapies, which have a single agent that we can often derive from a plant, figure out what it is, and then chemically synthesize it, we often forget that in plants there are multiple active ingredients. And so I'm going to encourage you to start thinking a little bit, open your mind up and think a little bit wider here than a single entity, a single molecule, and think about plant therapy, the entire plant. And I'll explain to you why I think that's an important component. But for one thing, for example, the chemistry and composition of cannabis is such that there are over 70 different phytocannabinoids. These are plant-derived cannabinoids that we know have similar cannabinoids that have similar sort of makeup to endocannabinoids that are in our own system. So they mimic chemicals that are already in our body. So these are plant-derived chemicals that mimic what we have in our body. Okay, and there's actually almost 500 distinct different compounds in these plants, and we're only starting to now understand and learn about them more and more. But again, the key ones that we understand really well are CBD and THC. All right, those are the two active ingredients that we understand better. The thing to keep in mind is that some of the controversy that comes around the use of the whole plant is that the plant will change what it's growing, how much THC it has, the kind of CBD it has, based on the climate it's grown in the soil it's grown in, how long it's grown for, etc. So there are some properties which are that haven't been sort of standardized by nature and give us different, and therefore they give us a different outcome in the plant. And it's not a dramatic difference, but it might be a slight difference enough to make one person taking it for one study respond really well, and another person taking it for the same study but taking a slightly different plant derivative not respond as well. So those slight differences can occur, and they might be just the different type of plant types. So we're understanding that now better in medicine and in science, and so what we're doing is we're standardizing how we grow the plants, and we're breaking down the plants chemically so we understand what's in them. And that's what we're using for studies now, so that we're actually making it more uniform, making our product more uniform, so that we can see what the true outcomes are in a more uniform manner when we enter into scientific experiments. So here's the real cool part about this whole plant, right? So I talked to you about THC and I talked to you about CBD, but there's a whole host of other components that we have now found that are very active in various aspects of disease. So these are, for example, terpenes. Terpenes are what give cannabis the smell. So THC and CBD don't have any odor. That's not what you smell. So when you smell weed, when you smell cannabis, right, what you're smelling is the terpenes. And these terpenes, by the way, exist in a lot of other flowers. Okay, so when you go and I don't cook, but if you go and use various different herbs, I don't cook well, but if you go use various different herbs, they all have different smells. Those smells are actually the terpenes that you're actually smelling. So terpenes exist in a lot of food groups that we consume daily now, all right? And they also exist in the cannabis plant, and it's also what gives the cannabis plant the smell, all right? Some of these have actually been teased out and have been shown to have effects on various different disease entities. So, for example, there are anti-inflammatory actions, there are anti-malarial actions, there are antibacterial actions, there are analgesics or pain control actions, there are anxiolytics, calms you down, they are various different, there's sedatives, et cetera, et cetera. So there's various different attributes that these terpenes have, and these exist in the whole plant. So this is why I'm encouraging you to start thinking about whole plant therapy, because imagine now you have THC and CBD, which actually have very strong activity for pain control, which I'll show you in a minute, but you also have all these additional components in the whole plant that give you these other activities that help you with the pain and management. Or for that matter of fact, it might be to help you with the sleep because you're having too much pain, anxiety, etc. Right? So there are other components that help out in the whole plant. In order to activate a lot of these components, we need to heat the plant up. And we need to heat it to a certain temperature to get the active ingredient out. Because the way they exist in the plant is as a carboxylated acid. So not the way you think of hydrochloric acid, but it's just a stable format sitting in the plant. And when you heat that, it releases the active component. So this is why, for example, for generations, people have, for example, smoked cannabis as opposed to, just consuming it. So this is where juicing, for example, has some controversy around it, because in juicing, you don't actually heat it up. You're actually using the unactivated format. But there are some benefits that have been shown there as well. Anyway, the reason I bring this up is because I will talk to you a little bit about smoking and vaping and stuff, just so you kind of have a sense of where this medicine's going. Let me just switch gears for a second here and talk a little bit about the endocannabinoid system so that you can have an understanding of why it works. So the endocannabinoid system, as I said, is really well studied. We understand it well. There are receptors. There are at least 2 receptors that we have studied well, called CB1 and CB2 receptors. They're found throughout the body, but the highest density is of CB1 receptors is found in the brain and in various parts of the brain. But the most important thing, I think, to take away is that what's really interesting is that there are almost 0 CB receptors and almost 0 endocannabinoid receptors in the brain stem. The brain stem is the part that controls our heart rates, and it's the part that controls our breathing. So when you hear about a fentanyl death in the media, the reason that fentanyl kills, or carbfentanyl or other morphine or other things, the reason that they kill is because the enkephalin system, so fentanyl, etc., have receptors in the brain stem. So there are lots of receptors in the brain stem. So when fentanyl hits the blood and then gets into the brain, it goes to the brain stem, it causes respiratory depression, and the person then dies, usually of a cardiac arrest, because there isn't enough oxygen to go to the heart, to allow the heart to pump, and they die. They have a cardiac arrest. This is what causes death from morphine, fentanyl, etc. Okay? Cannabis does not have receptors in the brainstem. You'd probably have to consume 30 or 40 truckloads full of cannabis to try and load up the brain enough, and you'd probably not be able to do that, right? And even then, chances are that you would just throw up and maybe feel sleepy and go to sleep. So there are actually no recorded deaths from the use of cannabis itself, as in terms of respiratory depression, I should say, specifically, the way that we have seen with the fentanyl crises. So that's the first probably myth that I would like to dispel, because I think one of the evils of this plant that has been sold is the fact that it can cause, that it's a drug similar to fentanyl, etc. But it's not. It doesn't have that same sort of ill effect. All right. So it's something to think about. We also, as I said, have a really clear understanding about how the systems work. Fairly good. I shouldn't say it's perfect, right? There's lots and lots of studies going on, but we have some good understanding about how it works. And so if you recall that whole pathway from when pain got to the brain and then back, in the brain, you now have receptors for cannabis, for cannabinoids. And these receptors actually, the way cannabis works, the way THC and CBD work, is by blocking the signals from one nerve to the next. So when the message comes up to the brain, the one nerve cell now communicates with the next nerve cell and tells it, this is a painful episode happening, do something about it. What cannabis does is it blocks that signaling between the two, it downregulates it, downplays it, so you don't have as much activity going on. So the interpretation of that pain or pain itself starts to diminish, right? So this is how we feel. This is one of the mechanisms of how cannabinoids work. It works in the brain to slow down that transmission of information so that you don't feel the pain. So you get pain relief, all right? The other way that it works is in the peripheral system. So there are CB2 receptors. Remember I told you the CB1 and CB2 receptors? There are CB2 receptors that are all over the body. And the main area that they sit on is in our immune system, where inflammation occurs. So when you now take cannabinoids into the system, one, they go up to the brain and stop that flow of bad information or information of pain. And two, it goes to the inflammatory system and it downregulates the inflammatory system. And inflammation, we know, releases a bunch of chemicals that cause you to sense pain, to feel pain, and makes the pain worse, especially neuropathic pain. So by doing this in a twofold manner, what you've done is you've decreased the central nervous system's interpretation of the pain. You've also decreased the inflammation in the peripheral system. So overall, you're diminishing the amount of pain. But also think about this. There are significant other advantages here. Why? Because we know, for example, that some of the receptors in the brain work on anxiety areas. So it's an anxiolytic. It calms you down. So it's nothing like being in pain, gets you all ramped up and anxious, but a cannabinoid can go in there and work on that system as well to create less anxiety. What about sleep? Because when you're in pain, you certainly aren't able to sleep, partly because of the pain, but probably because you're thinking about your pain and thinking about everything else too as a result of that. Well, we know that cannabis or cannabinoids also work on some sedation, and they work on similar pathways as known entities such as our sleeping medications, the benzodiazepines, right? So Cirox and a bunch of other sleeping pills that we as physicians prescribe our patients to help sleep. It works on the same sort of a system. So it helps with the sleep component too. So all of a sudden, you have a plant-based product that has multiple components that have multiple activities. And this is why some of the naysayers, you might say, in medicine and science say, well, this is like snake oil. It works on everything. How can it work on everything? Well, the reason it isn't really working on everything, but it's working on the root controller, right? It's kind of working on your CPU, your main information in your computer. So rather than working on a whole bunch of different lower level instructional things, it's working at the brain center of it all. So it controls a bunch of other processes as a result of that. So that's the way to start to think about why it has multiple effects in multiple different disease processes. It's not because it's snake oil, it's because it really works at a higher level before all the other disseminated pieces of information get down into the body, okay? Like any medication, like any plant, it has side effects. This is not a benign drug, right? We have to treat it with respect. So even though I'm telling you it's a very safe plant-derived medication, and it is, there are side effects, and we must be cognizant of these. Just like any other medication you take, from Tylenol to Advil to morphine to anything else, right? These are some of the side effects that we see commonly when we use it, and these are primarily due to THC, less so due to CBD. CBD doesn't tend to have as many side effects. But you can see things such as, drowsiness and fatigue, nausea, and a whole host of side effects that occur. Luckily, these side effects are generally not life-threatening. These are not life-threatening side effects that you see. But they do have side effects. So anyone that says it's a completely clean drug and won't have any side effects, they're lying, right? So it does have side effects to be aware of. The other argument that's used by a lot of my colleagues is, well, cannabis is a gateway drug. It'll get you addicted and you'll start taking, I don't know, cocaine, other things, right? So there are multiple levels of arguments that you can use against this, but one of the interesting things is that there are some great number of research articles that are been published now showing what the dependency. So we'll put gateway drug into sort of the dependency category, but there's a bunch of other arguments you can make about it not being a gateway drug, including a bunch of really good research out of the Mayo Clinic. But the dependency part is really interesting because this is a really interesting publication here. As you can see, in terms of dependency, you can see where it fits in the schedule of things, right? So you have things such as codeine and morphine, et cetera, the opioids, which are higher than cannabis. Alcohol, significantly higher. Cocaine, obviously. And then even nicotine, cigarette smoke, right? Very addictive. So if you really put it in the larger scheme of things, you can see how the dependency of cannabis, and especially when it's used in medicine, and there is a big difference there, especially when it's used in medicine, is almost, it's very low. It's not non-existent, but it's very low, right? So when you look at the overall harms, it certainly falls on the lower rung of that ladder of problematic drugs that we have in medicine. Let me just diverge for a second and talk a little bit about the about use of recreational versus medicinal. So I'm gonna throw a couple of controversial thoughts that I want you to think about. Okay, so I know when I've had a hard day in the OR and and I need to go home and relax a bit, I'll pour myself a scotch, and that helps me relax. That's alcohol. So when Joe down the street goes home and lights up his joint or vaporizes because he's had a hard day at work, he's also using the same sort of a chemical, isn't he, to chill out. Probably true. The important point that I think to make is that we have stigmatized cannabis in some pretty nasty picture, right, at times. And I'm not saying it's not without cause. I mean, there's obviously there's two sides to every coin. And I'm not saying that we should bury our head in the sand and say, no, this is a perfect drug. It's not at all. But if we utilize this drug in a smart way, we can take Joe and we can learn from Joe, because maybe I shouldn't be drinking alcohol, which is a class 1 carcinogen rated by the World Health Organization, versus cannabis, which is not a carcinogen, right? So maybe I've got something to learn from Joe and something I can think about, right? So just a controversial thought to seed in your brain. The other thing that I want you to think about also is medicinal versus recreational use. So in medicine, and I'll be one of my last slides will be going over this, but in medicine we used about 1/10 to 1/20 the amount of cannabinoids in medicine than a recreational user would use. So a recreational user will try their goal, a recreational user's goal is to get maybe high, right? In medicine, our end goal is not to get high. We consider that a side effect. The end goal is to actually treat the symptom, treat the pain, right? So I'm not sure if I'm losing my mic. You guys can hear me okay? So we have different end goals and different amounts of the cannabis or cannabinoids we're using. So when when a recreational user smokes, let's say they vaporize some cannabis, they're going to get about 10 to 20 times more of THC than we would ever use in medicine. So for most of my patients, and by the way, the average age of my cannabinoid patient is, I just looked at the numbers last week, is 71. So that's the average age of people that I'm treating with cannabis, right? So it's not the 30-year-old coming in to want to get high, right? It's a genuine pain-related and or muscle spasms, sleep, anxiety, etc. So that's the average age of patients we treat. But the important thing is that the amount of THC or CBD I'm giving them is about 1/20 what a recreational user uses, okay? Routes of administration. So if you think about, let's just think about fentanyl or morphine. When you're in the hospital and you're in pain, I don't know, I took out a kidney stone from you and you're in a lot of pain. I might be inclined to give you IV morphine. We'll give you some morphine through the IV, and within a couple of minutes, you're going to feel better, okay? But when you go home, you know, you can't go home on your IV, and you can't keep feeding you IV morphine. So maybe if I'm a traditional physician, I'm going to give you, fentanyl patch or morphine oral sulfate or some other form of oral or transdermal means of giving you the pain management, or a pill, right? So there are different forms or activities that we give people already. So cannabis or cannabinoids are no different. There are different ways that we can introduce it to a patient for either acute use, where you're in a lot of pain, or chronic use, where you need a low level of activity throughout the day. So smoking or vaporization, and I'm going to tell you why I think smoking is horrible, but let's say vaporization has a very quick onset. Within 5 minutes, you have pain activity going on, but it has a relatively shorter duration, 2 to 4 hours in your system, and then it wears off. All right. So it's got an advantage in that if you're having an acute crisis, lots of pain, you're getting in the medication right away. Oral, on the other hand, is something that takes longer to absorb. Oh, step back. Sorry, am I leaning too much? Okay, sorry. Oh, that's way better. I can hear myself now. So oral treatment works differently in that it takes longer to absorb. It's got to go through the GI tract. It's got to get absorbed into the bloodstream. It's got to pass through the liver, and then it gets to your system. So it takes longer to get into your system, but it lasts longer, 6 to 8 hours, right? So it gives you that nice longevity. And then there's other formats, right? So whether it's sprays in the mouth or transdermal patches or creams, etc. Those are not as consistent in terms of their absorption profiles, right? And that's true for any medication, not just cannabis, all right? So smoking. Smoking heats the cannabis up to anywhere between 600 and 900 degrees Celsius. It gives off carbon monoxide during the smoking process, and it potentially may give off cancer-causing agents that are in this plant that are being burnt off. Now, having said that, we don't have any studies, and it might just be because we haven't studied it adequately, but we don't have any studies showing that cannabis causes lung cancer like we do for nicotine, okay? But maybe it'll come in the future, so I don't have the answer to that. So I think the safer way to go about this is to say, you know, smoking cannabis will have the same sort of effect that nicotine might, all right? So it gives off cancer-causing agents. The other problem is that when you smoke cannabis, you lose about 30% of your cannabinoids. So 30% of your cannabinoids don't actually get absorbed into your system. So if you're paying, I don't know, $4 or $5, you know, per gram or whatever it is, you're losing 30% of your medication, right? On the other hand, vaporization has a much, you can control it better. You can heat up your cannabis or your cannabinoids to a certain temperature, and you get very little of the toxins coming off, and you absorb a much higher amount of that medication, all right? So when we start to introduce our patients, and usually it's through oils, that's how we start most of our patients out, but let's say that they're having acute crises and they're willing to try vaporization, then that's the direction we go for quick absorption versus smoking, which we discourage, all right? So driving and cannabis, I just thought I'd throw this in because I think this is an important thing to think about as well. Like any other medication, cannabinoids are also a medicine, also need to be treated with respect. You can have, you may have some level of sedation when you take cannabinoids, especially if you're taking THC for inflammation and pain. It might make you sleepy when you're driving and stuff. So bottom line is, if you feel impaired, don't drive. Don't operate heavy equipment. Don't do what you wouldn't normally do. If you, let's say if you were really tired. You'd been up for 48 hours and you're really tired. Well, you wouldn't drive, hopefully, right? Or you went out with a bunch of friends and you had a bottle of wine. You wouldn't drive. So treat cannabis in no different way in that way. Be safe about it, right? If you know that it's affecting you and making you sedated, then just don't drive, right? So some of the things that I touched upon, let me just kind of give you a quick overview, and then I'm going to give you some interesting take-home points here. So we talked about cannabinoids and how whole plant therapy is very beneficial because there are a bunch of other terpenes and other things within the whole plant that have benefits, have multiple benefits. We talked about the fact that when we understand cannabis, we understand the endocannabinoid system. When we understand the endocannabinoid system, we have a new system in which we understand how the pain nerves are being modulated, how sleep's been modulated, how anxiety's being modulated. We talked a little bit about what pain was and the kind of pain that cancer can cause, and the bony pain, which is often inflammatory in nature or fractures, and therefore cannabis having both a centrally acting ability to suppress pain, but also peripherally acting on the inflammation way of suppressing pain. It's a great drug to be able to use, a medication to be able to use for pain control. And then we talked a little bit about the safety aspects of cannabis as well. As I mentioned to you, I highly discourage smoking. I think there's multiple reasons, including the fact that you don't get your medicine properly and that there is potential for cancer. Which we don't have evidence for, but there is potential. That the fact that THC, that the THC content that we use to treat pain is about 1/10 or 1/20th or less than the recreational user. In our practice, when we prescribe cannabis, we start low, very low, and we titrate up to get your pain management. If you start to get side effects, you're getting too drowsy, you're getting high, you're feeling couch locked, or any of these side effects, these are side effects of the medicine. We say, okay, let's dial it back. We have to try either a different approach or a different combination with CBD and THC, because CBD does not, by the way, cause all those side effects. So all the side effects we're talking about are THC driven, right? So that is the sedation, etc. So we then change the ratio of CBD to THC, and we get something that fits correctly for the patient. We talked a little bit about, so basically the effects of the high. We talked a little bit about the recreational user versus the medical user. We talked about the safety aspects and the fact that the brainstem does not have receptors for the cannabinoids, and so it's very safe. We talked about the driving issues as well. So I want to end quickly with how the process works. Sorry, I hope that projects okay. But basically, the way that medical cannabis is being administered at this time before legalization, and I can't see why that would change after legalization, is currently the patient would go to their family doctor, have a discussion with their family doctor about the potential for wanting to try cannabis. There are a bunch of resources that we are happy to provide the family doctor who may say, I know nothing about it, I don't think it's a good idea. We are happy to educate our colleagues as well to help them understand where cannabis fits in all this. Once you've had that conversation, either your family physician would then go ahead with the process of getting you registered with Health Canada if they're comfortable doing that. If not, they would refer you to someone who does that. So for example, we run a clinic that does that. So we would get a referral from the family doctor. Then one of our physicians would then see the patient, do the evaluation, make sure that they're appropriate for this. One of our counselors would sit down and talk to you about what cannabis is, how to use it, where to get it, all that kind of stuff. So one important thing here is that dispensaries. So there are lots and lots of dispensaries out there. I'm sure there are some fantastic dispensaries, some extremely knowledgeable individuals in these dispensaries. But at this time, dispensaries are not the legal avenue to obtain cannabis. So until the laws change, The only place that you can legally get cannabis is through a licensed producer, and a licensed producer does not have a storefront. That is Health Canada's ruling. So the licensed producers, when they get the information from the doctor to them, they will register you. You will order on their website, and they will ship to you directly to your door the cannabis, the cannabinoids, okay, the oils and the plants. So at this point in time, that is the only legal avenue to get it. All right. I think there's. I'll take that in a second. I think there's, like as I said, I think there's lots of dispensaries that are very helpful and probably have very good products, but we can only speak to the legal route right now, and that's the only legal route right now. You had a question about that, I think. Yeah, so growing your own is absolutely a possibility. Yes, so I'll take that into the question and answer. I'll just end quickly by saying that once that information is gathered, we then fax a letter in to the licensed producer, and you're registered with Health Canada to be able to purchase the cannabis off the websites, and they get shipped right to your door. The actual container that you receive it in, that is your evidence of license. So as long as you leave it in the container, that is how you show that you have a medical license or medical letter to use cannabis for medical reasons. Okay, so I'm going to end with that for now. This is basically what I was just saying right now, and this is just our contact information. But we're not the only game in town. I'm not here to promote us particularly. I'm just saying that that your family doctors can do this. There are lots of physicians who are comfortable in doing cannabis work, and you can choose any physician that can help you with that. But we're happy to help through that process as well. So I'm going to end my talk there, but I'm going to take that question right off the bat, and before I take other questions. Is that okay? Do I have time to take some questions? Okay, perfect. So yes, you can grow for yourself. Again, you still need it to be registered through Health Canada. So what you do is you go to the physician would write the letter. Now, instead of me faxing it to the licensed producer so that you can buy from them, you would then get a hard copy of that letter saying, I'm authorizing you to grow, or I'm giving you the letter to grow. You will then take that letter with the application that's available online, and you send that to Health Canada, and then something happens in that black box, and you get back a little sort of certificate saying that you are allowed to grow then. And so that is the current, yes, you can do that. Of course, that medicine is only for you, and it's not to be subdued and sold and passed on to your friends or anything like that, right? So that's the whole idea of self-growing. And so yes, that is still available. Come legalization, as I understand it, you'll be able to have up to 5 plants, I think it is, per house. 2 plants? Oh, okay, I thought it was 5 plants. Anyway, so Health Canada or they will define exactly what that'll look like, with legalization as well. Yeah. Sorry, I didn't hear that. Okay, so yeah, absolutely. As long as you, repeat the question. Sorry. So the question was, is there an advantage to putting it in tea? So this gets back to juicing. So juicing and teas. So tea is difficult because teas you have to really heat up. You'd almost have to boil the cannabis to create the tea because you need to heat it up to that level in order to activate the cannabinoids, and then you can consume it in a liquid format. Cannabis and cannabinoids are not water soluble generally. They are oil soluble. So tea might be more difficult to actually get your medication into your body effectively, right? And it's going to be erratic. One day you'll have lots, and another day you might not have enough. So I think it's not as safe a manner. Same with juicing. Juicing basically works on using THCA, so that's the acidic form, and you're extracting that. But again, we don't have clear evidence of where THCA and CBDA fits in the pain management, but more so we don't know how much and how much of it you absorb because it's that liquid or acidic format versus an oil format, right? Yes. Yes. You'll have the same sort of, okay, so sorry, so I'll just repeat that quickly. The 2 questions were, how do you know the dosage when you're growing your own? And the second one was, there's other formats such as suppositories that maybe you can take, and whether that changes the side effects. I'll take the second question first, and that is, when you do a suppository, yes, that is a great way to absorb it. It's just another mucosal surface, just like your mouth, but the side effects will be the same. So if you're absorbing the medicine is what's causing the side effects. You'll still get the side effects, whether it's done. It should be the same, because it's whether you're absorbing it through the mouth or through the rectum, it should give you the same effect. But there are some local pelvic absorption that takes place in a different format, so there might be some subtle differences. I think it's individual to individual for sure. But so there is some benefit to it, for, no doubt, right? And then in terms of the dosage, so that's where you need to go see, like a cannabis clinician who can start you out on a very low dose. And usually for growing, we anticipate where you might get to based on your history and what you've told us and everything. And we'll say, we think you're going to get to this. And so we'll make sure that you've got enough of a plant count to get that. And then we back it down and say, don't take that much right off the bat. You start low and work your way up the ladder to get to the dose you want to get to. Okay, I'll be around. Afterwards, and so I think we're running short on time, and I'm happy to take questions as well and answer any questions you might. Thank you very much.
Thank you very much indeed. I've got a small gift for you here.